So good afternoon, everyone, and thank you for joining me. My name is Pam Kaiser. I'm the Vice President of the Clinical Resource Team here at PointRight, and we're happy to bring you this latest installment on PDPM called the Ripple Effect. Folks should know that we are recording this for future use, so if you have an issue or concern about that, now's the time to drop off. And at the end, I will be displaying on the screen how to access your information you need to get your administrator CEUs. So the first thing, when I was thinking about this concept of the ripple effect is I was thinking about how it is when you take something really important and large, and maybe not so large even, and you throw it into a pond, or the pond that we're calling SNF providers, that there's this ripple effect, right? And the part that's closest to the impact, so if you take a big rock like PDPM and throw it into the SNF world, the areas that's closest to that are the most impacted, right? The waves are greater. But there is effect as you move out through time and through other providers that work in the continuum of post-acute care. The impact's always, felt elsewhere. And so one of the things that brought it to mind was, 20 years ago, and I'm dating myself, when we converted to the new RUGS iteration, where we changed not only the payment methodology, but also the assessment tool, right? The MDS changed dramatically as well. There was an impact that was really not intended, and that was for dialysis patients in the hospital. So if you think back when RUGS first started, those folks were hard to place in a SNF. And part of the reason for that was you had to pay for the transportation to the dialysis center. A lot of folks didn't perform dialysis in-house. And also some of the medications that were given for dialysis patients, EPO in particular, were charged to the SNF under consolidated billing. And so what was the unintended impact was that all these dialysis patients were clogging up hospital beds. And so it took legislation and changes to the ruling in order to make that happen. And so I was wondering too, when PDPM happens here, will we be seeing any impact and what that might be? We're really not that mature in the process yet to really see all of the unanticipated or anticipated effects, but there are some things that we can take a look and explore together. So what I hope you are able to take away from this session is some ideas about where changes need to be made for SNFs when we're looking at processes to capture skilled services under this new methodology for PDPM. Should be able to, hopefully, if you're paying attention, be able to identify some potential areas of compliance risk under PDPM, and also some areas where post-acute analysis might be possible based on the data that PDPM now will have available to us writ large. So let's start with the area closest to ground zero, as it were, the skilled nursing centers or the skilled nursing facilities. When we think about reimbursement, obviously we always have to start with the MDS, with the minimum data sets. It's been critical for a long time to developing individualized care for residents, care planning, the cause, and the actual care plan itself. It's been important in outcomes measures, with the quality measures, whether they're quality reporting system, 5-star, all of the quality measures that are out there now, and also to ensure proper payment. And I come from a clinical reimbursement background. And, so when people say to me, oh, well, the focus in the MDS is changing, and, then we have to do different things on the MDS. I'm like, well, we always coded it to be accurate, right? MDS coordinators are anal by nature, and so they're very diligent about doing the coding. And then I started to think about it, and, it became so crazy with the number of assessments, with the COTs, with the EOTRs, the SOTs, the cadence of assessments that needed to be done, that it's very easy to think that some things could be missed, right? And this focus to verifiable resident characteristics may make changes in how folks are addressing or delivering processes around completing MDSs. Because really the critical factor for the most part was making sure that we got the therapy minutes and days in properly in order to get reimbursed at that RUG level. And now that it's really solely focused on resident characteristics, I think folks are going to be rethinking or revisiting some of these processes, right? As your focus changes, your processes and performance is going to change in different areas as well. And so looking at that through the lens of, all of these things are important now, where they were important before, but they weren't really driving your reimbursement. Now, these other areas that were always front and center from a quality and a care planning perspective are really going to impact your reimbursement as well. So you'll see changes most likely in your processes. And then also, your areas of risk will change, right? So when you think about what parts of the MDS you really need to be focusing on, what will you do differently or better when you're talking about monitoring? So sticking with the concept of, skilled nursing processes and changes, one of the things to think about is, how are you obtaining your supporting documentation, most specifically from the hospital? How are you getting that data? What are you getting? When are you getting it? How are you getting it? It's really a complicated task, and we were always trying to get these discharge summaries from the hospitals, and many times they got waylaid in the ambulance, or it wound up in the bedding, and the documentation never really made it to the SNF. And likewise, on the return, if we ever sent anyone back. But we really need to be focusing on collecting some specific data, particularly around surgery, around ICD-10 codes, things that are important for us when we're filling out that MDS, to ensure that we're capturing the non-therapy ancillaries, some of the comorbidities that will be important into categorizing each of the residents into their appropriate HIPS group. And we certainly don't want it to run into the danger of getting way too much documentation, because that's got a negative impact as well. I actually did see a really nice, well done check sheet that ancillary provider had created for case managers in the hospital to use when they were sending information to a SNF. And as I started to look down the list, they had meds, they had treatments, they have social service notes, they had dietary notes, they had nurses, they had, I said, you could just give them a document that says send the whole record. You really don't want to be overwhelmed with the data, but you really need to work with your hospital teams to be sure that you can get the information when you need it. Now, some hospitals have gone to the point of allowing providers to have access to their EMR, right? This concept of interoperability is starting to really become more important than ever. And so some of the security teams in the hospitals are looking at ways where they can give secure, targeted information to SNF providers, so that you'll be able to see that data and be able to get that information yourself, really streamlining that process. One of the challenges with that is making sure that that information gets into your medical record, so that when your teams are coding the MDS and looking for that surgical encounter or some of the data that they'd be interested in, that it's in the medical record when they go to complete the MDS. So ensuring that if you have that interoperability, that you then transfer it from a documentation perspective into your record. And sometimes the other new thing that seems to be gaining traction is this idea of a warm handoff. You hear about SNFists and hospitalists, using this call to share information so that when the resident hits the center, there's information already available in the clinician's eye. And similarly, we hear that happening between nurses, right? Unit manager or charge nurse or whoever, that there's this nurse to nurse handoff that happens as well. And again, the key thing there is making sure that you're getting your questions answered, what you need to capture on the MDS, maybe learning a little bit more about the family and their intervention with the resident, but also that that's getting into some sort of note in the medical record that this resident is coming or is here, and this is the information that we have about them, and that it's documented. So it's not just that you're getting it from the hospital, but that it finds its way into your medical record as well. The ICD-10 codes, critically important into establishing the category for the reimbursement for the classification for this particular resident. You probably have seen some codes rejected at this point, so making sure that you have the proper codes, that you're using the sequela coding, that it's not necessary, that's not the active acute diagnosis, as it's mentioned in the MDS manual. And when I talk about proper sequencing, it's not that sequencing is in order. It's obvious, that primary or the principal diagnosis has to be, identified. But the other diagnosis codes that you might want to use, section I-8000 has 10 slots, and we tend to really want to put every single thing in there, but there may be a time where, particularly with lots of comorbidities, these complicated patients that we're getting now and taking credit for under PDPM, making sure that the ones that are going to be meaningful to the care and to the reimbursement are the ones that we for sure capture, that they're active diagnosis and that they're captured in the proper spot. Lots of discussion with different groups and different conversations I've had with colleagues about this idea of refocusing on skilled nursing documentation. It's been therapy that's primarily carried the documentation because we've had people in therapy RUGS categories for forever. And the only people that really paid a whole lot of attention to the skilled nursing documentation were people who perhaps had the misfortune of being in some sort of post-pay review or pre-pay review, where they're really looking to see, is the treatment medically reasonable and necessary? And if the therapy is disallowed, what is remaining in the skilled nursing notes to support the need for skilled documentation? So really being sure that nurses claim their professional documentation skills back. I had a colleague of mine who a lot of folks know was recently doing experimenting with word smashes, where you take one word and another word and you push them together with a slightly different definition. And the one that I always have liked for skilled nursing is this documentation concept, that we've got to focus on documentation, and then affect. And if you smash them together, you have doc-effect, and that's the look that a nurse gives you when you ask them to write a skilled nurse's note. We've kind of lost that talent because we've been relying on other interdisciplinary team members to do that. So making sure that we're properly documenting the skill services we're delivering. What we're sometimes seeing too, as people are really starting to think differently on casting a broader net about MDS completion and skilled nursing process changes, is potentially reassigning some of the MDS interviews to other team members. Is it always going to be, or should it be, one discipline or another that completes the MDS interviews? And in some situations, therapists are stepping up. Many times, not always, but many times they have by virtue of what they need to do for their education in order to get that credential, they have lots of training and education. And is it somebody that would maybe be a good person to be assigned to go in and do the interviews? Again, just thinking larger and ways to maybe adjust how you're doing the work you're doing currently. The other process to really take a look at is, again, how are we looking at skilled level of care? Up until this point, it's the Medicare meeting and utilization review, and what's got to be different about how that meeting is structured now in order to make sure that we're catching what we need to capture to justify and support the need for skilled level of care in your center. And so the focus really of the meeting is going to shift away from minutes and days of therapy, obviously, to this coordination of care, right? Where are folks, what do they need? When are they getting it? Being able to identify changes in condition per your organizational guidelines. So how do we know that someone's condition is changing, and do they meet the criteria to have the next step done for an IPA or something of that nature? So again, how are we going to be handling that or capturing that information in this Medicare meeting as we sort of shift the agenda a little bit? For section GG, where we're looking at the customary performance, that assessment time frame, that look back time frame is 3 days. So making sure that we're capturing that information in the look back period, that we're having interdisciplinary team discussions about what we're seeing, because that score, it does have impact not only to the care and defining the functional status, but also reimbursement. And then lastly, again, there's probably others that you guys could come up with just by having participated in this new world under PDPM. But when are we doing IPAs, and are we following, again, the organizational guidelines? Another nursing process or interdisciplinary process that for sure we'd want to look at is this month-end triple check. Obviously we have the emphasis on the ICD-10 sequencing, running to make sure that we have the principal or primary diagnosis front and center, but how are we able to capture supplies or things that are not related to that are related to the non-ancillary services. So, if we are, have certain services, are we capturing, supplies or things that would need to be on the UB to show that we're supplying the information under like their Part B, but what they need to be capturing the total cost of care for that particular resident. And also, when we start to talk about billing and payment, anytime CMS goes through something as massive as this change in reimbursement and the reimbursement process, it's not surprising that we would have delays from CMS. So hopefully those are resolving, but it's always something to plan for in the event that in the not too distant future, they make adjustments and tweak the system. When that happens, we can probably forecast that there might be delays again. Another area that is worth reviewing, if you haven't done it already, is to look at your compliance plan or program. They've always been really critical and in many cases required. If you are under a compliance agreement, you know what I'm talking about. And with new rules of participation coming up, there will be others that will be, providing or having compliance programs. So those that have had them in place and know that they've been looking at areas of risk or concern when it comes to the MDS, clearly as those areas of focus shift on the MDS in the operational side, you're going to see a shift in what we're looking at from a compliance perspective. So gone are the times where we're counting out or making sure that there's documentation of the days and minutes in the medical record. It's going to be more about outcomes monitoring. And you'll hear that talk in the blogs, as people are discussing, well, maybe as their therapy is changing, do we have to be concerned about that, and what level do we have to be concerned? And the sort of consensus that seems to be mulling around out there is that it's going to depend on what your outcomes look like and how your resident moves through the care in your center. But shifting from therapy days and minutes to something else that's an area of concern or area of potential compliance concern is going to be important. Really focusing towards this proper capture of prior surgery ICD-10 coding. That's going to be front and center. We know that that impacts the reimbursement and what component category the resident falls into. So you can be sure that that will have scrutiny from external sources. So making sure that you have an internal area of focus to be sure that you're capturing that there's appropriate support for other diagnosis codes in the medical record in that look back period, that it's easy to find. I guess the other area that we've really looked at before, if you think about the PEPR reports and do you stand out as a provider in your area with more or less therapy, different kinds of ADL scores, remember what those PEPR reports look like. Certainly wanting to know if you're an outlier against ancillary utilization in your area or comorbidities that you're capturing in your area are going to be important as well. You'll want to just make sure that when you are looking at whether or not an interim payment assessment is necessary, that you're consistently applying your policies. It is voluntary. CMS fully expects to see IPAs for improvements but just make sure that you're consistent. And how are you going to be able to monitor that within your compliance program or plan? And then also, what's the quantity of interrupted stay assessments? We know the benefit for doing that is you get those 3 days of increased reimbursement on the ancillaries, that variable payment adjustment. But you just want to make sure that you're applying that appropriately and that it's not something to, as CMS would view, gaming the system. So paying attention to those things and making sure that you have appropriate focus and appropriate planning around catching those either never events that shouldn't happen or areas that are prone to weakness for a variety of reasons, but that you have a plan to make sure that you're monitoring those. As I mentioned, CMS did give us a heads up in this document. The bolding and the underlining is mine. It wasn't part of the actual slide deck, but they are looking for, this idea that we've got documentation that supports the diagnosis and the coding of the assessment, and that's going to have a broader focus on program integrity and data monitoring going forward. So it's going to be a larger review than just the therapy, and that they expect that the risk would be a little bit not as critical with as the therapy one would, because they're going to be looking at this documentation with a sharper eye. So in talking about rehab, let's see some of the ways that PDPM has impacted them. Obviously, there's this new group therapy definition under Part A where there can be 2 to 6 residents, regardless of payer source, doing same or similar activities, and under the supervision of a therapist or assistant that's not supervising anybody else. So this new definition has come into play. This combined limit of group and concurrent therapy by discipline is something that's new. And really, when I've started to talk to folks in the rehab arena, they did bring up an interesting point, and they, Pam, it's been this way for 20 years, and many of these folks that are coming up through the system now don't have the same experience with group and concurrent therapies as folks who may have been practicing longer. So there's education and training that's going to need to be supplied to therapists so that they understand the benefit and the value that these different modalities bring, and that they understand, how to document that appropriately and plan for it. That it's not always, even though we've been doing individual treatment for a very long time, there are benefits to these others, and how they can use that in their daily practice will be important to make sure that they're educated in those areas. We've seen and heard about discussions about revisions to contracts, that it's not just on the RUG category or the days or minutes delivered. And so there's lots of variation around the contracting that's happened with rehab. So, looking at, are there more opportunities for them to participate in interdisciplinary teamwork now that it's not such a push for the minutes and the days? And also, we've seen these value add options. I mentioned earlier about some therapy groups training their therapists to do the resident level interviews, making sure that they have the education and training. Not that MDS coordinators or social workers or whoever else is charged with doing those particular interviews can't do them, but is it's an opportunity to improve a practice, by having somebody else do the interview who might or might not be influenced with having to do a CAW around depression or something of that nature. So again, an opportunity to think a little bit outside the box. I also heard about a therapy company that was considering providing restorative aid, to their clients, depending on size, obviously. But, that then keeps that person from being pulled to the floor because they're not employed by the SNP, they're employed by the contracting rehab company. So lots of creative ways within contracts to meet needs of the residents. We've heard about rehab staffing changes already. I'm sure there'll be others that we'll hear about in the future. We've heard about, folks making a decision about whether they want to keep, an external contractor delivering their therapy services and have that system to remain in place, that process to remain, and others that have had the discussion about bringing people internally into their company and making them employees of that center or that organization. So lots of discussions about happening around staffing and what's the right staffing model. And we have heard about groups reducing staffing levels right out of the gate. So again, paying attention to that, we may see more of that happening, or they may decide that that wasn't the right course of action, and we'll see them reverse that. But these are all things that, PDPM is impacting as we start to move away from where the big splash is. Turning an eye to another group that's potentially going to be dealing with PDPM, and that's managed care folks. And SNFs that deal with managed care plans. Managed care plans have a fairly long runway to make changes. They have about 6 to 12 months, so they can wait and assess before making a decision about changing the terms of the contract, going from steps or to levels. Or whether they want to maintain, using some sort of a RUGS-based type arrangement. So they can certainly look at that. But most of them, really now we're seeing larger providers, bigger groups, really looking at either levels or a blended flat rate kind of arrangement, or some percentage of PDPM rate. And it's really a non-RUG perspective that a lot are doing, but they still can wait. I mean, I just wanted to make sure that folks knew that. And there's this idea that one of my colleagues floated, which I thought was kind of interesting, in that having a therapy level focus may have benefited some plans, because really we were in a therapy focused situation, right? A lot of our RUGs were determined by therapy. And so what happened in a lot of these levels is centers were focusing on delivering the amount of therapy to get to whatever the third tier or the fourth level was within the contract, and may have overlooked some of the clinical conditions that would put people into an equally high category. And so that the hypothesis is that in some areas where folks were not really paying attention, that might have, might make a difference for them on a go-forward basis. So again, things to think about when we're thinking about impact on managed care. Managed care will continue to grow. We see it happening on both sides of the country. We know that CMS really is trying to move people to non-traditional Medicare. Obviously, we know that because they're concerned about the, having enough funds in that federal program in order to pay for care as people are aging. So they're really being creative and looking to see for different ways to provide services. This is where you get your value-based purchasing things. But again, as managed care is continuing to grow and other alternative payment methodologies continue to grow, you can leverage your processes to do a better job in managing those contracts. So paying attention to the nursing categories or the nursing services that you're delivering with a new heightened awareness may benefit you in the long run when we're looking at managed care, being able to make better cases for the level of care that's needed and the amount of time that they need to achieve those goals in a thoughtful way. We still recommend completing your assessments, your MDS assessments on managed care folks. The ability to leave plans is a little bit more restricted than it used to be, but if they do have a change of plan, especially around the first of the year or the last quarter, you can may be responsible if you don't have an ARD selected. So you want to make sure that happens. And also there needs to be on any of the managed care invoices or claims that go in, there has to be a HIPS modifier, and CMS has said it can be the new ones or it can be the old ones, but there has to be a modifier on the claim. So we'll still see that requirement, and so needing to have that information will be critical for the managed care folks. When we think about hospitals or health systems, I mentioned earlier, the last time we went through a big change like this, we saw this interesting thing happen with these dialysis folks, and you can bet that hospitals are looking to see, what might be an unintended impact. When I was checking with a couple of folks in their state hospital association groups, They, hadn't really seen anything yet, but again, I think folks feel like it's early days and we haven't really matured past the October 1 switchover and some of those claims issues that we saw earlier. But, hospitals really need to be able to work with SNFs to be able to provide the documentation. And really the question is for the hospital, why is the patient going to a SNF instead of going home? And being able to have that front and center or clear in their documentation so that the SNF can then take it and use that information in their care planning and in their medical record to help guide their care planning process and billing. Again, we talked about this ICD-10 need, this codes that the SNF will need to be able to use. And again, it's for a condition that took the resident to the hospital, that arose while in the hospital or arose while in the SNF. So those are the ICD-10 codes that we're going to justify the Medicare Part A stay. The very important surgical procedures that we need to make sure that that hospital is aware of and can supply that information to your teams. And then, if you look at universal transfer documentations, that they're filled out completely, have a lot of the information that teams will need in order to answer questions about PDPM on the MDS. Again, this idea of sending the entire medical record really isn't workable. And so trying to find ways to get it in a targeted, strategic way is going to be important and also helpful when working with the hospitals. Really, the information that we're getting needs to be, provide the full patient picture. And we really want to see, what their needs are and the goals of care will be for them. And that comes from the transfer documentation. And, we may need on the SNF side, as we start to look at taking medically complex or potentially more medically complex than we have in the past, need to get some education and training in respiratory areas, trach care, some of these kind of advanced wound care. And so maybe the hospital can partner in collaboration to offset rehospitalization perhaps, or increase the patient experience by working more closely with SNFs and addressing some of these areas. Had an interesting conversation with a gentleman who was the CEO of a respiratory company. And one of the value adds that they wanted to bring was help with documentation. What are the types of things when the SNF staff is using their equipment, what do they need to hit on from a documentation perspective about time with the resident, what was done, those kinds of things. And so again, people are trying to explore ways to improve partnerships and help with documentation. Really, it's a good time to start to think about, as a hospital or as a SNF who works with the hospital, some of the collaboration projects that may have, excuse me, sort of fallen by the wayside a little bit because there just wasn't enough bandwidth to attend to them. Maybe as the MDS and therapy roles are changing, we can reinvigorate some of those collaborations and improve the care across the continuum, particularly thinking about readmission, rehospitalization, and the length of stay implications. We don't want, as a SNF provider, to get all hung up and say, I've got to get this resident out of the building because my variable payment stops after 3 days, and then on day 21 I lose 2% of what I'm making. If you stop for a moment and think, that variable payment adjustment is really a benefit that we haven't had before, because historically we didn't get paid any differently across the course of someone's stay, and capturing some of those costs up front is really beneficial to us. Obviously, on the 21 day and beyond, if you think about what 2% is off your total daily rate, that's really not a lot. And the length of stay nationwide is in the middle 20s. So, being thoughtful about the length of stay implications is going to be important, because what we don't want to have happen is to send people home because you want to get them home before day 21 and have them go back to the hospital, because that implication is much greater, right? If your rehospitalization rate is so high, you're going to lose 2% off of everybody for the whole year. It's not just going to be 2% off one resident in that one episode. So being thoughtful about that and working together to make sure that you're moving people through the continuum in an efficient, effective, and safe way is going to be where you want to develop those collaborative projects. And then also, where can you get quality data that you can provide to your hospitals for discharge planning? Shared outcomes by clinical cohort is important. And I'm not sure, from the folks on the phone that, hospitals have a new requirement under their final rule that was published for them from an implementation standpoint, that now as they're looking at discharge planning for residents, they have to bring quality data to the table that speaks to the goals and wishes of the resident in their care and selecting the next layer of care. So whether they go to a home health agency or they go to a SNF, the hospital discharge planners need to be able to provide quality data. So here's a great opportunity to partner with hospitals looking at data and data quality so that you can craft a good approach that serves everybody's need and, most importantly, the care that's delivered to the resident. Let's take a look at some accountable care organizations and value-based purchasing that is impacted by PDPM as well. When we start to look in these areas, value-based purchasing is looking at outcomes and rewarding good performers. Accountable care organization is looking at improving care, and then if they can do that in a fiscally responsible way to targets and sharing that wealth with folks that are in their continuum. And one of the ways that we'll be able to do that now is looking at the data that will be coming out with better diagnoses, with better comorbidity capture, and other things that are quantified. We have a better opportunity to work with these groups and CMS and show value, right? What happens prior under RUGs, the primary diagnosis, the diagnoses that you were seeing were general muscle weakness, generalized weakness, or the V codes for rehab for 2 disciplines post hospital stay. Not very informative when you're trying to grow a value-based purchasing program where you're paying for good performance, or where you're looking to see, who's a good performer with, particular diagnosis codes or different comorbidities, who does better with diabetic retinopathy patients who also may or may not have ulcers, those kinds of things. Now, under this new MDS capture, more of these diagnoses will be available, and so better programs can be devised around value-based purchasing. And also for the decision makers in accountable care organizations who are looking to see who is going to be in their program, who's not going to be in the program, and how they can make those decisions using risk-adjusted, evidence-based types of information. So really, these groups will be able to identify top performers. They'll be able to monitor more carefully the performance of the network or the people that are participating in that program. So having a better, more granular oversight capability is very, very helpful. When we're looking at that length of stay, again, under value-based purchasing and CMS, it's right now it's rehospitalization. That may change in the future, but again, it helps you know better if you're in alignment or not. And again, when we're talking about that length of stay conundrum, watch your rehospitalization rates. And then really, again, this clearer view into what does it cost to provide care to different cohorts of residents, and what can teams do to account for that in a better, more equitable manner. Continuing to ripple out when we start to look at analytics and how analytics will be impacted under PDPM. Really, we do a lot of data collection, and it's people are overwhelmed with it, so it's no surprise that data collection eventually is just not going to be enough, right? We'll have all this information, but we need to apply this now, looking at the data that we're collecting, looking to see what information it can supply to us as far as directional insights. Are we getting better? Are we getting worse? Do we have different performance measures that we want to look at, or different performance indicators that we can now capture and really use to its full potential? Can we predict outcomes based on data that we've collected? So moving not just from applying data to see how it's telling the story of your center or your organization, but how can you move data to help predict what your performance will be like in the future? And what does that help you understand about your practice now? Again, risk adjusting against state or local or cohorts that are meaningful for you. How does that help improve the context of the work that you're doing? And not only risk adjustment, but the benchmarks that are established in that area. Looking at ways with risk adjustment and other statistical methodologies that analytics can apply, how can we do a better job in comparing performance across the care continuum? And this is going to be important information, again, that CMS will be looking for and other external providers as we try to see, will we move to a uniform post-acute care payment methodology in the future? What is CMS looking at for that? And being able to measure more robustly or with greater detail, that information is going to be helpful. And then really, data analytics can help account for variables that will skew outcomes, right? So again, under this idea of risk adjusting, what are some of the variables that folks are looking at now that are skewing outcomes? And so that one provider looks like they're doing a better job than another, but when you actually get down to the, the real, the nitty-gritty of it, they're not necessarily doing that. The analytics that's provided, as I mentioned earlier, back to the hospital groups and ACOs can identify, who are the better partners as we start to move forward in lockstep in this care continuum and providing care for the resident in the most effective, efficient location. So that's the presentation for today. There is the handouts are attached to the webinar. And then here is the directions for getting your CEUs. You'll get a link to an online survey, so you complete that, or you can go to SurveyMonkey. Sorry, please disregard the date. And then you can forward that if you need to other attendees so that they can supply their information and get their CEUs. After you download the survey, the nurses' CEUs will be applied, and then the NAB ID is needed in order for us to report to NAB that you participated in the CEUs. Let me check to see if there are any questions in the chat box.
Pam, if you don't see anything, I do have one question that came in a little while ago, and it is asking an interesting question I'm not sure you might have the answer to or not. So how or what are facilities actually paying their therapy companies? You were talking about renegotiating contracts as people were preparing for PDPM. Is there something that's emerging as a common payment model for therapy companies? Is it a percentage of PDPM, or is this something that we're just not aware of yet?
That's a great question. I don't know how the dynamics break out. I did try to reach out to someone earlier this week in preparation for that type of question. But what I do know is that they're looking at levels, so different tiered levels of care. They are including, obviously if you're in business, you have administrative costs. So there's a flat rate that's sort of implied for that. But some are using percentages of PDPM and some are using some other methodologies. And, depending on how that's modeled, allows flexibility on the therapy provider to provide attendance at some of the interdisciplinary team meetings and those kinds of things. So I don't have a definitive business model that seems to be rising to the top. But if one does come up, appear later as, a front runner, we can certainly circulate that to the group. It's a good question.
Yep, absolutely. Another question came up, which sounds a little bit like a challenge, actually, asking if we have any templates for a perfect daily skilled nursing note to produce to support PDPM, and that's a that's a big question.
That is a
Um,
big question. I have heard that in some EMRs, they're looking at some of functionality where it's more of a drop-down type of thing. So based on a diagnosis, they have some click-through capability. Um, I don't have one. I have one that I used back in the day, but that was really geared towards a different framework. But we can certainly, put that on the roadmap.
Absolutely. So a couple more questions slash comments are coming in. One is a comment. HMOs seem to be asking for PDPM rugs, making it difficult because of Section GG. So I'm not sure if that means PDPM rugs or PDPM HIPS codes or rugs HIPS code, but obviously Section GD doesn't impact rugs, so that sounds like more of just a comment. So here's a good question. I've seen therapy decreasing staff. We've all seen news stories about that. But have you seen changes in decreasing MDS staff due to fewer assessments? This was the big news when PDPM was first announced. What's your take on that, Pam?
Right. Well, we did do a little, we did excuse me, look at that as far as, how much time does it take to complete assessments? CMS does publish that information. And then we looked at, the volume of the assessments. And then if we took out of the equation the assessment groups or the ones that were no longer need to be completed. And what we really found was that keep me honest here, Jen, I think it was like a 12% decrease in number of assessments, something
Yeah,
like
something
that.
like that. It wasn't enormous.
It wasn't enormous, and when you figured out the dollars and cents of the average rate of an RN doing that amount, that time, it really wasn't that much money. And I think what I would say is it's challenging enough to get qualified RN staff in a center to begin with, and that there's lots of work to be done around rehospitalization. We see that where there's a lot of quality reporting that's being done that's going to drive the bus in the future, and having skilled people who can assist with maybe creating more of a transitional care nurse or care coordination type process than a MDS nurse might be a model to think about. But if you have skilled, talented people in your buildings, I would think that you would be able to find a good spot on the bus for them as well.
Mm-hmm.
I don't know.
Absolutely. So here's this kind of dovetails this comment or question kind of dovetails into what you just said. My understanding of the discharge planning rule, i.e. the hospital discharge planning rule, it impacts post-acute care to post-acute care discharge, so would also impact skilled to home health discharge. So how can SNFs prepare for that?
That's right. So again, we're starting to see this focus on care transition because we all know that that's the weak link in the rehospitalization chain, right? That when when people transition through these care areas that they're most at risk. We drop a med or they forget to take them, whatever the case may be. It's just fraught with opportunity to have a misstep. And so I think this is part of what we're seeing, is to be able to provide good data on where people are going, and then it hopes that that will help match up skill sets and requirements, but also, help people do a better job in those care transitions.
Great, thanks, Pam. Another comment that came in from an attendee is that, again, kind of hooking on to what we've been talking about, is that that the concept of the aggregate of care services that qualify a patient as skilled. Remember the skilled
Right.
documentation, the skilled care requirements are not changing one bit, and often it's the sum total of services that add up to a resident being skilled in a facility, and that PDPM is really kind of turning the focus on that rather than how many therapy minutes did they provide and was that medically necessary. So all very key to tying it all together with the skill documentation.
Yeah, great comment. That great comment. Sometimes that aggregate of need is overlooked. I think, nurses, we
Mhm.
do assessments, we connect the dots of the care around these residents, and we do it so seamlessly and almost by rote that we don't really give it the credit that it's due when we talk about the skills of a nurse to connect those dots and to document the thought process that went behind driving the care based on gathering all the assessments, observations, and comments and assessments from other disciplinary team members. So that aggregate of need is many times overlooked.
Mhm. Yeah. But a question asking about therapy treatment diagnoses, of course, if therapy is providing treatment and there's a treatment diagnosis for it, it absolutely should be coded on the MDS because it is a reason for that skilled service being provided. It has to be medically necessary. There has to be a diagnosis for it related to the reason for why the therapy is being provided. It could be very well the primary reason why the resident's in the SNF, or it may be part of the aggregate of their need. So that was an
Okay,
answer slash comment.
good. So lots of people really noodling on this, and it's
Yeah. Um, so one more question. I think we actually have a few more minutes, so I'm keeping an eye out for more questions. So of course, sometimes it takes a little while to get hospital records, and a question asking when they finally get the records from the hospital and they find out that an IV was provided, IV medications, is it wrong to move the ARD earlier if the interviews will have to be dashed because they're not during the ARD window or before the ARD? Um, that's a tricky question. So my understanding of the question is that the ARD was set, let's say for later, let's say day 7 or so, and the interviews were completed with that ARD, but then it found out still within the window that an IV was provided in the hospital, but they would have to move the ARD back in order to capture that look back. What do you think, Pam?
I think that's perfectly acceptable within the guidelines in the RAI manual.
Mm-hmm. Yeah, the REI manual does say preferably before the day
Yeah,
before or day of the ARD. Of course, you really don't want to mess too much with doing things after the ARD, so that it is tricky. I think the broader focus though is if it's taking you so long to get that very important information that really should be in a transfer document from the hospital, then
right.
that's a broader issue.
And
Okay,
the other thing
so
you could
go
think
ahead.
about too, if you got that even after the ARD date, right? The documentation came in later, is a modification possibility if you've submitted it already. Other
Yeah.
things to think about.
Yeah. We're getting some messages from people who are already trying the SurveyMonkey link that the nurse CEU certificates has an incorrect date on it. So we are going to let our marketing department know about that and have it corrected. So for those of you who have already filled out the survey, we'll send you the correct certificate. For everybody else, just hold off until we send the follow-up email before completing that SurveyMonkey. So we apologize for that. Um,
Some people
okay,
really on the ball to get their
yeah, no kidding.
CEUs.
So here's another question about managed care. So for the managed care companies who are asking for the HIPS code that the admission MDS doesn't provide, however, then MDS folks have to add a 5-day to provide the HIPS code but not transmit it, which then add an MDS back and needing section GG. Our therapists still provide GG for all skilled residents and MDS completing section GG. So it sounds like this is kind of a workflow issue. Pam, you'd alluded earlier to recommending just completing an MDS anyway and combining it with the admission if possible. What do you think about that? We don't want you to go back and do more work.
No, obviously not. But having that information set. And again, you know, the managed care plan can use either the PDPM code or the RUG code.
It sounds like if a managed care company is requiring a PDPM HIPS code because it requires section GG.
Right.
Yeah. Okay, a follow-up on moving the ARD. If you end up having to dash the interviews, would it mess up the needed care plan? Well, I can answer that it would mess up the CA triggers. It should not in any way keep you from writing a care plan if
Right.
there's something indicated in those interviews that need to be care planned for. So I would hope that this doesn't happen very frequently, and then you could fix the root cause of that issue. With the hospital documentation, because you don't want to be submitting a lot of dashes, of course, because that will get you into trouble for other reasons.
Right, and that's, I mean, that's not the sole data that you use when you're devising a plan of care, right?
Yeah, yeah.
So you're using your
Remember,
clinical judgment.
the M and
Advisory.
MDS is minimum.
Right, right. So that's a great question because it is a concern when you dash those things. But I think the broader picture is you still have the time frame to create a care plan that uses all the data that's available to you.
Mm-hmm. So one more question, and then we'll wrap things up. So we're coming up a lot of questions that are relevant to what we've just been talking about. So what's your comment on this strategy? We would do a 5-day on day 1 to capture the IV therapy and from the hospital stay, because IV meds would count, and then or IV fluids rather, and then do the admission assessment on day 8. What would you comment on that, Pam?
So say that again.
Yeah, so do the 5-day on day 1 to
Yeah,
capture the IV from the hospital,
right.
and then do the admission assessment on day 8. I don't believe there's any more provision for pulling forward an interview from the prior MDS. That would be my concern of having to do rework, which
Right.
would be solved by just simply combining the assessments, if at all possible.
I guess the question then too is, you know, waiting to day 8, what does that gain you?
Yeah,
You know,
yeah.
depending on, you know, but if you've set the date, you can look at that and make a decision.
Right. I mean, and setting the ARD, once you set the ARD, an early ARD to be on the safe side, it can still be moved as long as you're
You're
within
within
the
the time
first
frame.
day, 8 days of the stay.
That's
So
right.
if you can still make it work and combine it with the admission, and you know the resident's going to be there beyond day 14, then you may want to flex that ARD a bit if you can flex it far enough to combine them. Phew. All right, that
Really
was a
great
bunch of
questions.
questions at the end.
Yeah. Well, I think it's a lot of people have been thinking about it as they've been, you know,
Mm-hmm.
getting their feet wet, so to speak.
Right, and kind of mulling over the issues. So, all right. Well, thank you, Pam. I know I've been jumping in here, but thanks very much for providing this great information. Again, any further questions, please feel free to email us, and we'll be happy to follow up. And remember, please hold off on filling out the survey until we send our follow-up email so we can fix the date on the nurse CEU certificate.
Great. Thanks, everyone.
Take care.